All right, welcome. So for lab three, these are the learning objectives. Please note that everything about the cardiac axis has been taken away, the electrical axis of the heart that has been taken away. And these are the structures that you need to be able to identify. And so, where's the heart? Of course, it's located in the thorax. It's a little bit displaced towards the left, and it sits in a little groove of the left lung. And so the apex is down here, and the base, of course, is at the top. And this is a cartoon of the same thing. These are some of the vessels you need to know. The pulmonary trunk, of course, the heart sits in the pericardial membrane. The pulmonary trunk, the aorta, those are vessels you need to know. So if I look at this, first the question is, how is this oriented? Is this oriented anterior, or is this the posterior side? Well, how do you know? This here is your vena cava, superior vena cava. So this must be the right atrium. And so this is going to be the right ventricle. And of course, this here would be the left ventricle. And this is the sulcus, interventricular sulcus. So what are these two vessels? So this is my aorta that is really thick right here. And here is my pulmonary trunk. And this again, question, which is what view is this? Is this anterior or is this the posterior view? First, how do we know? There are several ways to know. Again, this one here on the left is anterior. How again do I know? This is my um, right atrium right there. So remember, you have to flip yourself. So that's the right atrium, and this here is my interventricular artery. Okay, interventricular, so the two ventricles, and it sits in that interventricular sulcus. It's an artery, and right here will be my coronary artery. On the back side, how do you know this is a posterior? Several things. This is my coronary sinus. That's the big vein that drains the heart muscle and drains and dumps into the um, right atrium for that blood to go and be oxygenated again. And so this is posterior. What is this right here? That looks like bagpipes. That's your left ventricle. And into the left ventricle, you have two um, pulmonary veins, okay, that dump into the left ventricle. Again, so you should be able to identify all of these things. First key thing is always orient yourself to know what is left and what is right. And you should always, of course, I use the left atrium. That's a good one to orient yourself with. So the left atrium, and if you can see the pulmonary trunk, which is typically thinner than the aorta, thinner in terms of the thickness of the wall of the vessel, then you're looking at the anterior side. And this is a posterior side. Telltale signs will be the coronary sinus, as well as um, the left atrium. That's a good telltale sign that you're looking at the posterior side. That's the external anatomy of the heart. The vena cava and the superior and the inferior vena cava. If you touch them in lab, they have it's like very flimsy vessel because again the veins do not carry pressure; they carry a lot of volume. And then you have your pulmonary artery that branches off of the pulmonary trunk. You have the left and right, and those carry blood back to the lungs to be oxygenated. Beneath that are your pulmonary veins that are returning from the lungs to bring oxygenated black blood back to the left atrium, and that goes to the left ventricle and out the aorta. And so that's the aorta, and you see three branches on it: the brachiocephalic trunk, the carotid, the left carotid, and the subclavian. So we'll talk about that in the next lab, but just know that those three things off of the aorta is a telltale sign in case you you thought it was a pulmonary trunk. That's a telltale sign. Okay, so talked about the coronary sulcus, and in there is my coronary artery, right coronary artery, and the left is typically kind of hidden under like the pulmonary trunk and all the fat tissue. And so we identify that the posterior side, my bagpipes or my ventricles right there, um, and my coronary sulcus right here. And I have a posterior interventricular artery. So the interventricular is not a good way to orient yourself because there's an anterior one and there's a posterior one. On the posterior side, the coronary sulcus, the coronary sinus is your telltale right there. Um, you do not need to know any of these additional muscle vessels. Inside the heart, so blood comes in through the vena cava, either the superior or the inferior, and then once it gets in, what happens? It gets into the right atrium. It goes through the your tricuspid valve. So if you look at the section of it, so look at how it has three cusps. Oh no, not that one. Sorry. It has three cusps. I can't show it really well here in this section, but the acronym is LABRAT. Um, LABRAT. So the right AV valve is the tricuspid. So that's that. And from here, it goes into the pulmonary artery and or the pulmonary trunk, which breaks into the left and right pulmonary arteries. And that goes to the lungs. And then on the right side, so that goes to the lungs and then comes back through my pulmonary veins, left and right, um, here as well, and gets into the left atrium. And so we're here now in this image, so we're in the left atrium. Then it goes through the bicuspid valve. So left atrioventricular valve is the bicuspid valve. Um, so again, look at this one has one papilla, two papilla. This one has one papilla, two papilla, three papilla, papillary muscles. And so that's a bicuspid on the left. Another way to remember, bicuspid on the left, bile. The layers of the heart, the epicardium, myocardium, endocardium. The endocardium is the innermost layer um, that blood is in touch with. And then the myocardium is the actual muscle, and you have an epicardium that comprises some connective tissue and outer epithelium. And so here are my valves again. So this is going to be right AV valve. It's tricuspid, and this is my bicuspid left AV valve. And then you have the semilunar valves. One goes into the aorta, and the other one goes um, into the pulmonary artery. Why are these valves important? Again, they're crucial for preventing blood eversion. That is blood flowing back into the atrium, um, which would not be good. So really quickly, here is a cardiac muscle structure. It's a little bit different from your typical striated muscle, like a skeletal muscle. Like all muscles, it comprises actin and myosin. But the question is, where exactly is the actin and myosin? It is striated. You can see like these faint lines here. Those faint lines are where your sarcomeres are in that vessel. So that's the sarcomere is the unit of arrangement of the muscle where you have actin and myosin um, in close proximity to form cross bridges. So those little wavy lines are um, is where your sarcomere. And so what else here? So now you also notice like this other they also seem wavy, but um, they are thicker. Okay, so you can see all of them right here. Those are your intercalated discs between adjacent cardiac muscle. Those intercalated discs perform crucial functions. They have a mechanical function. So mechanically meaning they hold the adjacent fibers of the heart muscle fiber together. The adjacent fibers, it holds them together because of the tight the gap junction that is in between them. But those gap junctions also have holes in them, and those holes are like little pores, and those pores allow the cytoplasm of adjacent vessels, adjacent fibers, to be connected. So again, this is one interconnected disc right here, where the two fibers, this one and this one, are basically sewn together, stitched together. And so that's a mechanical function. Otherwise, if that wasn't there, your heart muscle fibers can pretty much share and break apart, which will not be good. And so that's a mechanical function. The other function is, well, another mechanical function sort of is just allowing the cytoplasms to be in contact. But that serves actually more an electrical function because that allows um, action potentials. Let's say action potentials are coming from this way in this particular in the cytoplasm. Cytoplasm is water and it has electrolytes, so it will conduct electricity quite well. Let's say it's coming down this way. Well, when it gets here, how does it skip to the next um, stitched on muscle fiber? Well, it doesn't need to skip. Their cytoplasms are directly connected through the intercalated discs. Other things about cardiac muscles, they could have several nuclei, one or two, and they're branched. That's pretty unique. And so anatomical structures, let's talk about the electrical activity. So here is my SA node that generates the current. So I'm going to do two things at the same time in this graph. So when that electric current this thing depolarizes, so you have an atrial depolarization, atrial depot, guess what? That is read on the EKG as a P wave. Okay? So the depolarization goes, and goes to the AV node. Guess what? The AV node basically causes a a temporary delay about I want to say about 100 milliseconds, I believe, or no, about 20 milliseconds. And that very short delay is an isoelectric line, and that segment is called your PQ segment. Okay, that segment there's nothing happening mechanically. Okay, well there is, but you can't see that on the EKG. But electrically, it's basically it's like a stall signal. So there's a stall over here. Um, the muscles of the atrium also contract here as well during this period. But electrically, what is happening is you have a delay in the AV node. Now, and then once things begin to leave the AV node, the current begins to travel down the AV node. There's an initial time when it seems to be going like in that direction. That little going in that direction away from this axis, negative, positive axis of the heart, that little period of going away from that axis causes a little negative dip. And so that becomes your Q wave. And then once it now begins to go down the Purkinje fibers to the muscles, that gives you a huge deflection because that's the biggest part of your heart, your ventricles. And that forms your R wave. And then as it turns upwards, again away from this direction, because the depolarization goes that way, then it comes back down again. Now you have your S signal. And then when the heart is being repolarized, that is coming back to its resting membrane potential. It really doesn't have a resting membrane potential, but it's coming back to its normal. It's repolarizing for the next depolarization. Then you have a T wave. So that's what the EKG measures. So here are the segments again. So your PQ segment. So first of all, that's atrial depolarization. Boom. Um, in that PQ segment, there will also be, um, so I'm going to put mechanical activity here. There will also be um, atrial contraction, but the atria empty their blood vessels. They don't really need that much of a contraction. They won't. If you felt the atrium in the lab, it's quite flubby. It's quite floppy. So it does still contract, but that's by then 80-90% of the blood has already gone into the ventricle. So there's still atrial contraction over here, but the key thing is electrically, it's a delay at the AV node. That's what's significant here. So I'm going to call it here electrically AV delay. Okay. So the QRS complex is ventricular depolarization. That's the electrical activity. Okay. Again, here your atrium is probably still contracting, but you can't see that at all. Mechanically, the ventricles have not begun to contract yet. They're full of blood, but they have not begun to contract. Now, the next segment is called the ST segment. And in the ST segment is when the ventricles let loose. So in this period, the most significant thing is the ventricles contract. Okay. So after that is done, then you come back to um, repolarization, which is a T wave. So that's my repolarization. So notice here that throughout the QRS complex, the volume inside the ventricle is still constant. But once you've finished your QRS complex, guess what? The volume now begins to go down. Okay. That going down is what's called your systole, your contraction. So remember, electrical activity um, precedes muscular or mechanical activity. And then once the in repolarization, the heart is now the ventricles are repolarized, so essentially they're relaxed. They've come to their baseline, and they're now they don't the pressure inside them has gone down, and blood is now going to be coming in from the ventricles again, from the atrium again into the ventricles. And so guess what? The ventricles begin to fill up, and then once it's full, um, notice here that at the end of the P wave, again, electrical activity precedes mechanical activity. Guess what? The ventricles begin to fill. This is due to active filling. So this is just passive, just dumping from the atrium into the ventricle. But the extra pump here is what gives you that little bump to eliminate everything. So if you think about it, um, most of it was already filled. So this is like 150. Here was already about one, I want to say 135. So it's about 90% full here just by passive filling, and the remainder is due to the contraction of the atrium, which is why I said that there is some atrial contraction happening here, but that is, it's a very small amount of blood that it does pump. And then, so together, this period here is called diastole. and this period is called systole. That's when the blood goes out of the body. Okay? So, which of these is abnormal? A, B, C, D. You can select more than one. Um, well, which of this is normal? Are these normal? Take a quick look at that. And so, another thing we did in lab was to measure the EKG, and there is a separate video for that. But quickly, if this is 11 seconds, and this is how many RR intervals? This is one interval. Hear me out. One interval, a second interval, a third interval, 4, 5. So I have 5 RR intervals in 11 seconds times 60 um, seconds over 1 minute. That gives you the heart rate in that scenario. Please do not count this as again, we're counting intervals, right? If you count 1, 2, 3, 4, 5, 6, you would have counted wrong. Okay.